What's going on, my healthcare brothers and sisters? I hope that you are having a wonderful day. My goal is to help you pass your NCLEX and your nursing exams like a boss. And today we're going to be talking about metabolic acidosis when it comes to our arterial blood gases. Let's get our nurse on. So we've already talked about the respiratory component when it comes to respiratory acidosis and respiratory alkalosis. I highly recommend you go back and watch those videos because that's really going to give you an in-depth view of what's happening with those particular patient populations. But today, we're going to be looking at metabolic acidosis. So what's happening in metabolic acidosis? Well, it's a total concentration of buffer base that is lower than normal with a relative increase in the hydrogen ion concentration resulting from loss or too much base and or retention of too much acid. So I just said a whole lot of words. What the heck does that mean? It means that we're going to have a low pH and a low bicarb. Remember when we talked about in our Rome, respiratory opposite, metabolic equal, both of our signs are going to be pointing the same direction. We're also going to have an increase in lactic acid or base deficit, and we're going to talk about those in separate videos. So the most common acid-base imbalance that you're going to see in hospitalized patients is going to be metabolic acidosis. Why? Because when it comes to our respiratory components, they're going to happen pretty quickly. But when it comes to our septic patients or anybody with any kind of acid-base imbalance, you're more likely going to see metabolic acidosis before you see anything else. So a memory trick to help you remember metabolic acidosis is base is stored in our intestines. If you poop it out, you lose your base, right? So that causes metabolic acidosis. Base is stored in our intestine. If you poop it out, you lose your base. If our kidneys fail, acid persists. So we're going to have high hydrogen ions in our urine because our kidneys are failing, leading to a more acidic state, thus metabolic acidosis. So we have quite a few causes when it comes to metabolic acidosis. What we do know is that we have an increase in metabolic acids and a decrease in our bases, our HCO3, our bicarb. So why does that occur? Well, you're going to see it a lot. And the most common time you're going to see it is when it comes to our diabetic or diabetic ketoacidosis patients because they have an insufficient supply of insulin, causing an increase in fat metabolism, leading to an excess accumulation of ketones or other acids, thus depleting our bicarb. So when you've got these DKA patients that you're taking care of on your floor, you're going to see a lot of metabolic acidosis. And honestly, it seems like nowadays, especially where I work, where I'm an educator, we see a ton of DKA. So it's really good to know what that is. If you haven't seen my DKA video where we go over in depth what diabetic ketoacidosis is, I highly recommend that you go check that out because it's going to be extremely helpful in taking care of that patient population. Another cause could be renal failure, increase in waste products or protein metabolisms are retained, acid increases, and bicarb is unable to help maintain balance. So the kidneys really help regulate our bicarb. If we've got some kind of renal failure, we're not going to have that bicarb regulation, leading to a more acidic state within inside of our body. And lastly, again, severe diarrhea. So we talked about before, bases are stored in our gut. So if we're pooping it out and we're having this extreme loss of our bicarb, we're going to become more alkaline. Intestinal pancreatic secretions are alkaline, and losses of these secretions cause acidosis. You can see metabolic acidosis a lot too with our high-fat diet patients. So you've seen a lot of these patients on these particular diets. I won't go into the names, you know what they are, but these high-fat diets can cause these respiratory acidotic states because it causes too much accumulation of waste products from fat metabolisms, leading to ketones and acids within the body system. Lactic acidosis is another huge one. Again, it's in the name, acidosis. Our oxygen supply is not sufficient for the metabolism of carbohydrates, so lactic acid is produced and lactic acidosis results as a byproduct of that production. And then lastly, ingestions of poisons, toxins, and acids. Those are all going to cause acid-base imbalances, particularly metabolic acidosis. So if you intake excessive aspirin can lead to an increase in hydrogen ion concentration as well as antifreeze. So what are we going to see? What is going to be the patient presentation of our metabolic acidosis patients? Well, we really need to assess for the cause of our metabolic acidosis when we're taking care of these patients. So neurologically wise, again, we know that the brain is very sensitive to changes in pH as well as oxygenation. So you can see lethargy, confusion, dizziness, headache, even potentially coma, depending on how bad that acidosis is. Cardiovascular system, you're going to see that decrease in our blood pressure, dysrhythmias related to hyperkalemia from the compensation. Like we talked about in our previous video, potassium plays a huge role when it comes to our buffer systems with our acid-base balances, because hydrogen ions, as we have an increase in hydrogen ions, the body is going to compensate and try to get rid of them, right? So they are going to push all of that excessive acid, all of those hydrogen ions, inside the cell. Well, potassium and hydrogen ions have an inverse relationship. So as more hydrogen ions are going into the cell, more potassium electrolytes are going to come out. So it's going to increase our serum potassium levels, leading to hyperkalemia. So if we've got these hyperkalemia states within our body, we're going to start seeing all of these dysrhythmias take place because of that hyperkalemia. So you can start to see peaked T waves. You're going to see a lot of dysrhythmias take place depending on how severe that hyperkalemia is. And lastly, you're going to have cold and clammy skin when it comes to metabolic acidosis. So gastrointestinal system, when it comes to patient presentation of metabolic acidosis, you're going to see nausea, vomiting, diarrhea. We talked about it before, our base is stored in our gut. It's in our intestines, right? So our stomach stores the acids. If the body is too acidic, what does the body do? It's going to try to get rid of the acid. So you're going to see it be ejected either through your vomiting, through your stomach, or diarrhea through your gut, right? And because of all of this vomiting, diarrhea, of course, you're going to start to see abdominal pain when it comes to these patients. Neuromuscular system-wise, we're going to have muscle weakness due to that hyperkalemia because the hydrogen ions are being exchanged for that potassium inside the cells. And respiratory system-wise, you're going to see deep, rapid respirations. It's a compensatory action of the lungs to try to help that metabolic imbalance within our acid-base system. It's also known as Kussmaul's respirations. So you're going to see that a lot, especially with our diabetic ketoacidosis patients. Depending on how severe that acidosis is, you will see these particular respirations. As well as you're going to see increased respirations that help compensate for metabolic causes. So it's not necessarily just those deep, rapid respirations. You could even have a patient that's trying to hyperventilate to try to balance out that acid that's taking place. It's the lungs' way of trying to compensate for what's happening metabolically within our system. So something else that you may notice, especially when it comes to diabetic ketoacidosis patients who have metabolic acidosis, is anion gap. And if you've never heard of anion gap, I did a video that went into depth about this, but we're going to touch on it briefly here in metabolic acidosis. So when you have an anion gap acidosis, it's really the measurement of the difference or gap in between our negatively charged anions and positively charged cations electrolytes. So if the anion gap is too high or too low, it may be a sign of a disorder in your lungs, kidneys, and other organ systems. So what does that actually look like? What does the equation look like for our anion gap? So it's really our cations versus our anions. So our cations is our sodium plus our potassium, and our anions is our chloride plus our bicarb. So we take the sum of those two equations and we minus them from each other. So we minus our cations from our anions, and that gives us our anion gap. So in an acidic state, potassium will be pushed out of the cells in exchange for hydrogen, causing an increase in potassium outside of the cell. So we're going to have more positively charged electrolytes, right? So these changes are going to further increase our anion gap. So what does the medical management look like for our metabolic acidosis patients? Well, again, we have to fix the underlying cause. If we are throwing all of this treatment at the patient and we're not fixing the underlying cause, we're not going to see a whole lot of results when it comes to metabolic acidosis. So particularly when it comes to diabetic ketoacidosis management, we're going to give insulin as prescribed to move glucose into the cells and decrease that ketosis. So what that does is that glucose becomes metabolized and the body will stop converting fat to glucose, lessening that acidosis. But we also need to monitor for circulatory collapse caused by polyuria. When you've got all of this glucose, the body is going to try to get rid of it, and one of the ways it does that is with increasing urination. But if it increases urination too much, it can result in osmotic diuresis, causing extracellular volume deficits because of that hyperglycemic state. So we really have to monitor these patients very closely that they're not becoming dry and that we're fixing the blood glucose issue that's leading to that diabetic ketoacidosis. You've also got renal failure management as a big one. So an indication could be dialysis to remove that protein and waste products depending on how severe that acidosis is. It'll ultimately lessen that acidotic state. We can also give a diet low in protein and high in calories, decreasing the amount of protein waste products and lessening the acidosis that way as well. And then lastly, we can give sodium bicarbonate. It's a buffer that helps with acidosis if it's severe enough that we're not able to fix the underlying cause. So we can always give sodium bicarb. I've given it a lot, especially in our open heart ICU patients and just general metabolic acidosis patients in the ICU. It's really a great medication, but it has been used sparingly from what I've seen because sometimes, depending on how severe the acidosis is, if it's not severe enough, you're really not going to use it. I hope that this video was helpful in helping pass your arterial blood gas nursing school exams as well as your NCLEX like a boss. If you haven't done so already, make sure that you subscribe here to my YouTube and hit that notification bell so that way you're informed every time I post a new video. You can also follow me on my social media. I am on Facebook and Instagram, and make sure that you check out my website at www.nursecheung.com. There I'm going to have NCLEX style questions, resources, handouts, everything you need to pass those exams like a boss. But until next time, I hope that you're having a wonderful day, and I will see you all again soon. Bye!